Do we have too much government?
We need to put people ahead of corporate profits.
This system is so lopsided.
This threat is a real threat to democracy.
And I think that's really important. That's something we haven't been doing in this country for a long time.
Where do you start? What do you do? How do you do it?
Access to Democracy is sponsored by Thomson Reuters, providing legal professionals with the intelligence, technology, and human expertise they need to find trusted answers. Products include Westlaw, Practical Law, and Firm Central legal practice management software for small law firms. Thomson Reuters, the answer company. Online at thomsonreuters.com. Access to Democracy is made possible in part by a donation from Firefly Credit Union. Firefly is the new name of U.S. Federal Credit Union, which has proudly served the financial needs of the Greater Twin Cities community since 1925. At Firefly, we guide our members forward and give them the power to chase dreams by delivering the financial solutions they need to get ahead. From checking accounts to mortgages, we'll light the way. We are Firefly Credit Union, and this is Life Illuminated. And Dr. Charles Crutchfield of award-winning Crutchfield Dermatology in Eagan, acknowledged as one of the nation's best physicians. A Minnesota native who trained at the Mayo Clinic, Dr. Crutchfield personally treats all patients and states that experience counts and quality matters. Crutchfield Dermatology. Look good, feel great, with beautiful skin.
Welcome to Access to Democracy. My name is David Schultz. I'm your host today for this show, and let us talk about healthcare today. One of the things that's interesting about healthcare, as I think back at least for the last 20 years, if not 30, if not more years, is that there seems to be every 4 years a declaration that there's a crisis in healthcare in the United States, that we need to do something. Take us back to 1946 when Harry Truman was president, giving a famous speech and saying that what we need to do is to provide access to health care for everybody. Yet we know that that's been a long struggle, and in 2009, the Affordable Care Act, otherwise known as Obamacare to many, was passed by Congress as an effort to try to solve the health care crisis in America. But now here we are, 8 years later, and there's all kinds of debates about still needing to do something, whether at the federal level or at the state level. And that's what we're going to talk about today. We're going to talk about healthcare in America, but more importantly, healthcare in the state of Minnesota regarding what is the crisis, what is the problem, and what we can do about it. And my guest today is Senator John Marty, and Senator John Marty has recently written a book called Healing Healthcare, of which we're going to talk about a little bit today. And I want to welcome you, Senator Marty, to the show.
Thank you, David.
Good. So I want to start with something really quite simple. At least the question's simple, the answer may not be, which is, what is the problem with healthcare in America? And if you even want to bring it down to Minnesota, what is the problem when we say there's a healthcare crisis in Minnesota? What is it in your estimation?
Sure. Bottom line is, even though we have the best doctors, nurses, clinics, hospitals, medical technology and everything, we've got the worst system in the world for accessing it.
Okay.
And there are two huge problems caused by that difficulty with access. One is the cause of that, or part of it. That's high cost. Mm-hmm. And the other one is a lot of people don't get the care they need. Okay. And all of the reforms of the past 34 years, at least most of them, 30 or 40 years, have been designed, if healthcare is too expensive, let's try and make it so people don't use as much of it. Let's put barriers in their way, whether it's tighter networks or co-pays and deductibles.
Sure.
Or insurance companies excluding things from coverage. All of those things have been designed to make sure people use less. And after 30 or 40 years, that's probably been somewhat successful. A lot of people can't get the care they need, but we're still spending twice as much as any other country in the world spends on health care, and we're getting worse results. So I'd say the crisis is the fact how many people are struggling to pay for health care, how many people simply don't have access to it, and how screwed up and convoluted the whole system is.
Right. So when we talk about there being a crisis in healthcare, it's not one problem, it's multiple problems. And again, as you're describing it, one is the affordability issue, I think, but for the individual. I also think you're sort of suggesting here, it's not just at the individual level, but as a society.
Right.
We're spending too much money on healthcare.
We spend, again, compared to other countries, we're spending over $9,000 per person. A family of four, $36,000, and most families of four say, I don't spend that much. Well, half of that cost comes from government, another quarter is paid for by private sector businesses, about a quarter by individuals and families on average. So yes, it's very much a problem. And it's not just the 5% in Minnesota or 10% nationally who don't have any coverage. It's the other 95% as well who have coverage, but it excludes things like dental care. They have huge deductibles. They have co-payments or things that aren't covered. The bottom line is a lot of people, about a third of the public, will say in any survey that they did not get certain care they felt they needed for their health in the past year.
Okay, so this is good. So it's even for those who already have access. It's still the affordability. It's the range of services that they're getting. It is the society-wide compared to other countries in the world, how much we're spending on it in terms of healthcare. So it's a whole cluster of a variety of problems, correct?
Yeah, absolutely.
Okay. So let's take us back to 2009. In 2009, we at the federal level, the Affordable Care Act passed. MNsure was what, 2009? Also 2010. 2009. And supposedly
the actual MNsure didn't actually get implemented for about 4 years later, but yes, it was part of that initial thing with the Affordable Care Act.
Right. Okay. And so where I'm going in terms of discussion here is that a lot of people describe and say, well, the Affordable Care Act was going to solve the healthcare problems, that MNsure was going to solve the healthcare problems. Why didn't it? If it didn't?
Right. It did not.
Okay.
It didn't make them worse. I mean, in a few ways, it may have made things a little less good, but overall, it took about half of the people who were uninsured and gave them coverage. It took
and that's good. That's good, though, isn't it?
It's a huge benefit.
Okay, that's good.
Enormous benefit. So when I'm being critical of it, I want to make sure, realize, hey, it covered 25 million or more Americans who didn't have any coverage. A lot of people who had severe healthcare issues, they had lifetime caps on how much their insurance would pay for, and they couldn't get care they needed because they had reached those caps. A lot of people with chronic conditions couldn't get insurance, not because they couldn't afford it, but because nobody would cover them. So a whole lot of issues that the Affordable Care Act fixed. But the way I describe it is we have such a convoluted patchwork of ways of people getting access to health care. And the Affordable Care Act plugged a few holes here and there, but sometimes in a patchwork, when you're plugging some holes, there are new leaks spring up and so on. And so it made things a little bit better, but again, it's not solving the problem. And I would have argued, and I argued back then, it wasn't a solution. I had been chairing the Senate Health Committee in Minnesota at the time, and I argued that we could copy no one system, but copy some concepts and some values and put them into law and make a system that would be far cheaper and far better.
Okay, so why didn't, more specific, why didn't, again, MNsure and Affordable Care Act, I'm going to kind of link them together. Why didn't the ACA solve things? In fact, listen to Donald Trump, President Trump, listen to Republicans. They're arguing and saying that it actually made things worse. Do you agree, disagree, or we'll start with that. Do you agree or disagree?
The only part where I'd agree on is it may have added to some of the instability of the individual market.
Okay.
But that's partly because it required them to cover all these difficult to expensive, well, I should say sicker patients.
Sure.
And so it may have done that, but the rest of it, when they come into office saying, hey, we're going to repeal this, the first thing we do, and then now Trump is saying, well, he hopes to have an outline of a plan in March or April and hopes to have legislation that he could pass by the end of the year. Well, they're finding out that it's a convoluted, complicated system, and if you're going to just keep plugging holes here and there and you're going to pull out some of the previous plugs, it's still going to be a huge mess, and they're going to own the problem then.
Right, okay. So if you were thinking about a direction, and I know this is what your book is about, a direction in terms of reforming healthcare, are there some basic goals that we ought to be thinking about in terms of what a good healthcare system would look like?
I think your choice of the word goals is perfect choice of word, because the way I describe it, when you're going on a trip, the first thing you need to know is where you're going. When you want a healthcare system, what are the goals?
Right.
And as I mentioned earlier, most of the goals of healthcare reforms in the past decades have been to bring down the cost.
Right.
I'm saying, forget about that for a minute. If you want a healthcare system, if you're going to design a new healthcare system, why don't we focus on trying to design a healthcare system that keeps people healthy and gets them the help they need when they need it? Focus on the goals. So I actually think, other than just the general concept of trying to keep people healthier and help them get the care they need, I put together a list of 10 principles, goals of what a healthcare system ought to be.
Sure.
I put in place a proposal that would meet those goals, but I don't care. They don't have to use my proposal.
Right.
Anybody who can design a system that meets those goals, fine with me. And the goals were obvious things, it seems to me. Maybe some people disagree with them, but first one is it should cover everybody.
Okay.
100%. You know, if Poland and Taiwan and Slovenia, not just the first world nations, Japan and Germany and England and France and major first world nations, but a lot of, quote, second world nations perhaps,
Sure.
if they can all do it, we can do that. So cover everyone.
Okay.
Second thing, cover everything.
All right.
Why is dental care separate from everything else? Your teeth are as important to the function of your body as your fingers and your toes are.
Yeah, or even your eyes.
Yeah, or your eyes. We don't have separate finger and toe insurance.
That's right. That's right.
So why do we need separate dental insurance?
Sure.
And long-term care. Seniors even have separate prescription drug insurance. You know, why do we have to have that kind of system? And so we want to cover everything. The third one we want
And I
to
also throw in there, it should probably also cover a lot of the issues that have been excluded by the Affordable Care Act, such as in some situations, contraceptives.
Right, right.
Yeah.
It covers all medical needs, because the main thing in terms of trying to have a healthcare system that functions in keeping people healthy and so on is making it patient-centered, people-centered. Who should choose which doctors? And one of the principles is who chooses which doctors and providers you go see? You do. You, the patient, decide. Who makes medical decisions? You and your doctor, not some insurance company, not government, nobody but you and your doctor trying to figure out. Your providers are giving you the medical advice and so on, saying, I'd recommend this for you. And you're saying, well, but what are the risks of this? And that's the kind of thing should be decided between the patients and their providers,
Sure.
not insurance companies or government. So the third principle is that one. Another one is that we focus on saving money by efficiency and so on, and banning the plan from cutting off services to save money.
Okay.
In other words, no rationing there. But we have another one which most plans don't even think about. No state thinks about this, and that is, one of the problems with access is cost. The other one is there aren't enough providers of some type. There's a great shortage of psychiatrists, great shortage of general practitioners like family practice doctors, especially in some rural communities.
Right.
Well, this plan would be legally required. One of the principles that are legally binding on this proposal would be that they have to make sure there's a sufficient number of providers to serve the needs of the community, which means you're not going to have waiting lists, which is a problem in some countries, not many, but some have a problem with it, including ours. Right. But make sure there are enough providers, make sure providers are paid on a fair basis. So when you were asking goals, that's what I'd say. I have these 10 principles.
Good.
And again, anybody who designs a healthcare system that meets all those, you can count me in. And I don't need my proposal if they'll meet those proposals, those goals. And again, so you start with the goals and you design a system around those goals.
Okay, good. Now, I know you've been a strong advocate for many, many years of a single-payer system. Explain what a single-payer system is, and then I can use that as a sort of an opportunity here to get us into a discussion of what you actually have written in your book. So describe what a single-payer system is, because I think people have all kinds of images of what it means and what it suggests like that. And I think people confuse it with not just single payer, they can confuse it with like single deliverer sometimes service. So can you explain all that?
Sure. I don't often use the term single payer to describe my proposal because you said people often don't understand. Most people either love it or hate it, but they don't have a clue what it is.
Exactly.
And it's not a very descriptive term. That's one of the reasons I don't use it. It's kind of like I ask you, you're buying a new car. I ask you, what are you buying? Dealer financed. And I said, well, yeah, but what kind of car?
Yeah.
Well, dealer financed. And you keep being emphatic about it. It's dealer financed. Well, that doesn't tell me much.
Right.
But a single payer, what they mean by that is instead of a hospital or somebody billing 20 different insurance companies and all the patients and getting co-pays from here and that and some government funding and everything else. Instead of hundreds of payers paying the bills, you have one payer and everybody pays their premiums to that one payer and then it pays all the bills. So that's what a single payer is, and my proposal would be what they call a single payer, a single administrative system for it, but multiple providers, most of them private, as we have now. We have some public hospitals, a lot of private hospitals. It wouldn't really change that, but a single payer is, instead of multiple payers, you're having one entity pay the bills.
And one type of insurance for it too also, I think,
Yeah,
isn't it?
what I would describe it is that payer is, currently it's many insurance plans plus government and so on. We would have one plan. I don't call it an insurance plan because it covers everybody, so I don't see it as an insurance plan. It's getting rid of the insurance. But it would be a single plan that pays the bills. And that also really does explain where you get the efficiency and why this current system is so convoluted. Yeah. And that would be to make an analogy, if I can, between the way we fund the hospital and the way we fund the school.
Okay.
And if we funded our schools the way we fund our hospitals, at the end of the day, or maybe during lunch break or something, every teacher would have to sit down for half an hour, 45 minutes, calculate how much time he or she spends with each of the students and any resources he or she spends on them. And then they'd send it down to the billing office, and then they'd have to fold in all the administrative overhead, the utility costs, maintenance costs, and so on. And then they'd bill all the school insurance plans of all the families. And some of them would not cover everything, and some of the people wouldn't have any plan, and some of the people couldn't pay the co-pays. So not only would you need a billing office, you'd need a collections office.
Sure.
And the question that raises is, how does that improve education? You're taking teacher and administrator time away from teaching into bookkeeping.
So we're making them become bookkeepers and not teachers.
Right. And how does it save money? It doesn't. It costs a lot more. You're adding a huge new function there. And that's sort of the difference. Our schools are a single payer. In effect, the school district pays all the bills for each school, and that's the way they fund the schools, and that's sort of what we'd be doing with the healthcare system.
Right. And so we'd have some savings that comes from eliminating some of that extra work.
I would argue you'd save at least 15% just on the elimination of that bureaucratic system.
Yeah, I remember hearing a talk from I think it was the president of Mayo Clinic a few years ago, and I may be slightly off in the number, but he had said something to the effect of when people come down there for treatment, they have computer programs that have to run, I think it was like one of 2,000 different insurance programs to try to figure out, because, and I remember doing this as a school exercise once. I used to have my students in one of my classes call up a hosptal and ask for a price quote for, like, I first started with appendectomies. I thought that was too complicated, but I remember all these hospitals were advertising their birthing rooms.
Right.
And so I said, okay, call a hospital and ask, how much it would cost, for like a regular childbirth. And the hospitals freaked out. They couldn't tell you.
They couldn't give you that.
They couldn't give you the answer. And they said it varied on not just the condition of obviously the patient, but on the insurance. And so it just always amazed me at how complex it was that you can't really do that.
If you tried to shop around, which people want to do when they're buying very expensive things,
and some
you
people
can't.
and some people have wanted us to do that as consumers of healthcare, to say we should shop around with our healthcare to try to figure
it won't work. I mean, I had neck surgery a few years ago at Regions Hospital. The bill was $21,000.
Yeah.
My insurer only paid $7,000.
Yeah.
I only paid $200. Who paid the rest? Well, nobody did, because for this case, they had negotiated a $7,200 thing for $21,000. If you didn't have any insurance, they'd hit you for the whole bill, and you might not be able to pay it. So it's a bizarre system.
It is. It's bizarre. And so your goals are partly about insurance, but to be clear, but it's also about the delivery of how we actually deliver healthcare in the United States and in Minnesota, correct?
Right. I think we should make it work as simply as we can for people, again, patient-centered. For instance, where is the best place to deliver healthcare to kids? Well, during much of the year, they're in school. And when I was in kindergarten, we got the flu vaccination, not the flu vaccination, the polio vaccination.
My spot's right here.
Oh, I got a sugar cubes. We were thrilled as kindergartners.
Yeah.
Now I think I'd rather have the shot than the sugar cube. But,
Yeah.
But they lined us in the gym, and
Yes.
one after another they gave it to them. When our kids were little, if we wanted to give them a flu vaccination, which they recommend for every kid, my wife or I would have to take off work, go to the school, pick them up, take them to the clinic, get an appointment usually, take them, get them the shot, bring them back to school, disrupting our time hugely, very expensive, disrupting the teacher's day and everything else. And then you get maybe 40, 50% of the kids get flu vaccinations when they recommend everybody gets them.
That's right.
It's far cheaper if you had a school nurse deliver it.
Sure.
So we want to have a system that makes sense.
Right. So tell me a little bit about the proposal, because your book outlines a proposal,
Right.
and I assume you have legislation in the Minnesota Senate that's loosely based on, or based on
Very
what you've
much
written in the book.
based on it,
Right.
right.
So tell me a little bit about your proposal.
Sure.
Is there a Senate Senate
Senate
file?
File 219.
Okay.
And it actually has very many authors. It has like 60 some authors between the House and Senate bills.
That's good.
So we're very pleased with that. It's not something that the current majority is sympathetic to.
Okay.
But the reason we wanted to put it out this year again is because I think as bad as the healthcare system is now and as expensive and every other problem, I think the proposals I see on the table now are going to make it worse.
Okay.
And they're certainly not going to make it better, and people are getting more and more scared about their healthcare costs. So I actually think at some point people are going to say maybe it's time to fix the system instead of tinker with it.
Right.
So, but the system, the proposal, Minnesota Health Plan would be a inclusive system, covers everybody for all their medical needs. People would pay for it by paying premiums based on ability to pay. So even if you're low income, you can afford it. Everybody pays something. Some people pay more. But we'd pay premiums based on ability to pay. You wouldn't have any co-payments, deductibles, other excluded care because it covers dental and everything. And the plan, Minnesota Health Plan, would pay all the doctors and providers around the state. It would also be financed by a business payroll tax.
Okay.
And between the two of them, that would replace the half of the money that's currently being spent by employers and individuals. The other half funded by government would just continue to go through.
Right, so this is important clarification here. So under your plan, let's say you're currently working for, I don't know, Acme Widget Company or something like that, and they're providing health insurance. Under your plan, the state would now be taking over the health care, and Acme Widget would no longer have to pay into it?
They wouldn't have to. They'd have a payroll tax as a Minnesota employer,
okay.
but beyond that, they wouldn't have to, and they wouldn't have to have their own plan anymore for their employees. I mean, it's a strange system we have in this country, historical anomaly, as you know, about why employers provide the health care coverage. It was their way during the price controls in World War II to attract employees.
That's right.
But now you see whether the Hobby Lobby case or Alina in their nurses strike, the employer is saying, we want you to go to these doctors, we don't want to cover this thing, we're going to do this. And a lot of people think, why is my employer making healthcare decisions for me?
Yeah.
And so, but the biggest problem, and employers benefit from this, would be that they don't have to shop around every year, especially Acme Widget Company, which may not be the biggest company in the
Small
world.
little company, maybe 25 people?
Employees, and they have to go shop around, and each year they're going to come back, oops, it's 12% more expensive than last year, we got this. Not only do they have to spend a lot of time negotiating that, but then they have to educate their employees on what's covered, what's not covered. Take away all of that bureaucratic gobbledygook, and their employees have better coverage than they have now.
Right, and it also helps, I think, stay with those smaller companies also. It helps those small mom and pop companies who want to do a good job and hire people, but for many of those companies, it really isn't affordable to be able for them to get health care, to get health care for their employees.
If 5, 7, 8 years ago, there was a survey of Minnesota mainly Twin Cities, mid to larger sized employers. This was shortly after the recession, asking them what their biggest obstacles are to creating jobs. It wasn't what the chamber often says, taxes or regulation or whatever. It was cost of health care.
Yes.
And that also causes other problems. They discriminate against older workers because they're more expensive to cover. They discriminate against people perhaps with disability, not legally, but when you're hiring, you're figuring out these costs.
Okay.
So it gets rid of a lot of those problems.
Good. So it's going to be universal coverage in the state. It will be coverage that will be financed both by the existing monies are there, plus you said a business payroll tax. Okay. Now, how will this affect if this were to go into place, how will this affect in terms of how people actually access health care? Because I can see somebody saying, oh my gosh, the government's taking over this now. Now the government's going to tell me what doctors to go to.
You know, that's the one thing whenever people say, oh, I don't want government-controlled health care. I say, yeah, I don't either. That's why we got this proposal.
Yeah.
Because if you don't want government-controlled health care or insurance-controlled health care, this is a proposal for you, because the government cannot tell you which doctors you go to.
Okay.
The government cannot tell you what kind of care you're getting.
Okay.
The government cannot tell your doctors to do this or not do this. You and your doctors make the decisions. You don't have somebody looking over the doctor's shoulder. I mean, we now have insurance companies who are requiring prior authorization, they call it, where they have to give approval before certain procedures or certain medications or things are done. They're now requiring prior authorization for diabetics to get insulin. Wow. Which becomes a huge hassle. If you talk about doctor burnout, doctors who are tired of checking boxes and filling out forms, the current system is killing them. And to me, the idea that doctors and patients make the decisions, that makes sense. Yes. And the one thing people say is, you say this is going to save money. How? Well, aside from the administrative expenses and so on, aren't people going to overuse health care? Don't we have to ration it? Somebody, government, insurance companies, somebody. And I say, well, if there's any rationing health care, it should be done by patients and their doctors. And what do you mean? Well, like a lot of other things that are expensive people use, food or cars or whatever else, healthcare is very expensive. But unlike those other things, most of us, we may like our doctors, but we don't like to go visit them.
I don't know anybody who wants to go see their doctors all the time.
It's not like, hey, you get next Monday morning, you got a few hours off because it's President's Day, and you want to have, well, I think I'll go get me a colonoscopy. That was so much fun. People don't do that.
They don't.
And so realistically, you know, any empirical evidence between other countries and us or economic studies in this country suggests that covering everybody in a logical, simple system without the insurance bureaucracy is actually cheaper than what we're doing now. Even covers more people for more things, and it still saves money.
Okay. We're starting to run out of time, but what are the prospects? What are the prospects? You think it's going to pass this year?
No.
Okay. So what is the long-term game plan?
Okay. I was hoping to push the bill this year. DFL does not control either the House or Senate, which I was hoping would be a different outcome. But the current leadership will not support this. I'm hoping, I've asked for a hearing, but I don't know if I'll get one.
Does the governor support it?
The governor has been supportive of the concept. He hasn't been pledged to it. But I think there's very slim chance this year, but I think a huge chance in 5-6 years because the system is breaking down.
Terrific. Good. All right. Thank you, Senator Marty, talking about health care in Minnesota and in terms of the reforms that we need to make. Is there anything we can recommend?
Sure. Well, if they want to read the book free, it's available online in ebook, Kindle, or whatever, or PDF for those of us without readers.
That's right.
At mnhealthplan.org. MN is in Minnesota, healthplan.org. That's where they can get the book free to read online or whatever.
Good. Terrific. Thank you very much. Thank you for coming on to Access Democracy. Again, Senator John Marty, and good luck to you with your proposal on health care. This is Access to Democracy. Thank you.